Hello everyone. Good afternoon. Good afternoon. Welcome to another Sunday chat with Dr. Madeline. Thank you so much. I'm going to give everyone just a couple of minutes to join and then we'll get started. Today we're going to be talking about endometrial cancer, 3 things that I think are really important for you to know. Okay? So thanks again. Thanks for joining. This is Dr. Madeline and we'll get started in just a couple of minutes. As you come in, please hit like and share in case you think there's someone who might also like to hear this information, and then we'll go ahead and get started. Again, thank you for joining today. As you come in, please hit like and share the page if you can, especially if you have someone who might be interested in this information. And again, today we're going to be talking about endometrial cancer, okay? Endometrial cancer is also sometimes called uterine cancer. So sometimes people ask if there's a difference there. Hey, Lee, thank you so much for joining. I appreciate you being here. Thank you so much. So yes, sometimes people refer to endometrial cancer as uterine cancer. So again, if you have some sister friends or some guy friends who might be interested in this topic, please by all means encourage them to come on in and watch. We're going to be talking about endometrial cancer for the next about 15 to 20 minutes. So again, thank you for being here. As you come in, please just wave or type hello in the chat, and we're going to go ahead and get started in just a couple of minutes. I hope you all are doing okay overall. I'm enjoying this fall weather. This cooler weather is very refreshing. Hey, Sean, thank you so much for joining today. Thank you. I appreciate y'all being here. As you come on in, please wave or say hello, or just say hi in the chat. Again, we're going to be talking about endometrial or uterine cancer today. And so if you know of anyone who might want this information, please feel free to share. And also, please don't forget to like the page. Again, thank you for being here. Okay, so let's go ahead and get started. My name is Dr. Madeline. Thank you again for joining me on Sunday Chat with Dr. Madeline. I'm your board-certified OBGYN, international speaker, and published author. I really am passionate about working with women, busy women especially, to help make sure they get the specialized and tailored gynecology and birth control services that they need. By doing this, I help make sure that women can access as much freedom and control over their lives as possible. And isn't that something we all want? More freedom and control over our lives? So that's one thing that makes me really excited to be here with you guys today. So, please, if you are interested in hearing more information and getting more feedback about what's going on and what I'm talking about in the world of GYN and some other public health information as well, please feel free to check me out on Instagram, Facebook, and Twitter as Dr. Madeline MD, and that's DrMadeline MD. Okay? All right. Thanks, everyone. So I said we would talk about endometrial cancer today, which is also known as uterine cancer. So I think what's most important, you guys know that I'm very visual, so I'm going to start by making sure that we're all on the same page in terms of knowing what endometrial cancer is. It's one of the gynecologic cancers, and this month is the month of September is when we pay attention and highlight. Hey, Janet, thank you so much for joining. I appreciate you being here. As you guys know, this is a month when we really try to highlight and make more women and everyone aware about different GYN cancers during the month of September. And so that's one reason why I've been covering so many different GYN cancer topics. So just so we're all on the same page, when we talk about endometrial cancer, we're talking about the inner lining of the uterus, okay? This inner lining. You heard me say that it's also known as uterine cancer, and that's because when endometrial cancer extends through the lining to inside the wall of the uterus, that's known as uterine cancer. So the early stage of endometrial cancer is just this lining right here, okay? And as the cancer progresses more, it moves into the uterine wall, into the muscle of the uterus. And when it moves outside of the uterus, that's a more advanced stage of endometrial or uterine cancer. Okay, so endometrium, the lining, myometrium or the uterus itself is uterine cancer, and then leaving the uterus and going outside is a more advanced stage of cancer. So, hi, ladies, thanks so much for joining. Hi, Dr. Terrellin, thanks for joining today. I appreciate you being here. Thanks again, everyone. So that's what we're going to be talking about today: endometrial cancer or uterine cancer. And again, I always like to start with some demographics, just so that you guys are aware of how common or uncommon this may be. So it's estimated that about 55,000 new cases of endometrial cancer are diagnosed just in the U.S. every year. 55,000 is a lot. And so that's another reason why I thought it was important that we cover this topic today, this topic of endometrial cancer or uterine cancer. So there are going to be three things by the end of this talk today. There are going to be three things that I want you to know and that you can keep in mind in terms of whether or not you have questions, or if you know someone that has certain symptoms and they're talking to you. Forgive me, I just want to make sure I turn my phone off. And that way you'll have some information to give them some feedback, or you can always, come back and put a question on my page if you have other questions or concerns. So the three things I want to talk about in terms of endometrial cancer, the first thing I want to talk about is risk factors. What are some things that we should keep in mind as, we're going through our lives as women, or if there are men watching, men who help and love and support women, what are some things to keep in mind? So some risk factors for uterine cancer include anything that increases the amount of estrogen in our bodies that is not met also with matching progesterone. So what that means is in women who have polycystic ovarian syndrome, they have more estrogen in their bodies, and so sometimes that estrogen, because it's not met with opposition, can lead to a hormonal state in the body where there's not a balance. So there's a hormonal imbalance whereby they have more estrogen. Hi, Michelle. Thank you so much for joining. I appreciate you being here. So one of the risk factors for endometrial or uterine cancer is unopposed estrogen, or having an excess of estrogen in your body. So that's one of the things. Michelle, let me just show this again, because I started by just making sure that everyone understood what I meant when I talk about endometrial and uterine cancer. So endometrial cancer is the lining of the uterus. When that cancer goes into the wall of the uterus, that's called uterine cancer. And when the cancer goes outside of the uterus, that is a more advanced stage of endometrial or uterine cancer. So other risk factors that I want you guys to be aware of: if someone has a family history, a close first-degree relative where there was either colon cancer or ovarian cancer, that can also increase someone's risk of endometrial or uterine cancer. That's something definitely to be mindful of. Obesity. Having a BMI of 26 or higher, and I know a lot of us, including me, have a BMI of 26 or higher. I just put it out there because this is what the science shows. But when you have that BMI, what happens is, in the excess cells that are in our bodies, more estrogen is made in those cells. And so that's how it kind of ties into the science. When you have, again, just like polycystic ovarian syndrome and other things that can increase the estrogen in your body, being obese or having a BMI of 26 or higher is one thing also that's correlated with an increased risk of endometrial cancer. Okay. Other things that have been associated with endometrial cancer, when you look at scientific data. Hi, Debbie Brown. Thank you so much for being here. I appreciate you being here. So other things that are correlated with an increased risk of uterine or endometrial cancer include diabetes, and in some studies hypertension, not conclusively in terms of hypertension, but certainly diabetes, the studies have also been conclusive. One of the things I want us to be mindful of, especially depending where you live in the country or depending on your racial ethnic background, some of the things I've mentioned as risk factors tend to be documented more commonly in different groups of people. People who live in the southern part of the United States tend to have higher rates of obesity and diabetes. And so when we look at some of the data as it relates to endometrial cancer, there have been some studies that have suggested that in different parts of the country, depending on what's going on in terms of demographics and everything, endometrial cancer is one thing to be aware of in case someone comes in with certain symptoms. Of course, in other parts of the country as well. Oh, I have a question here from Janet. Does endometrial hyperplasia cause an increased risk? Janet, thanks so much for that question. It can actually, if it's not treated. So one of the things that happens is, and I'll talk more about how we check for endometrial cancer, but if someone has endometrial hyperplasia that's diagnosed, one of the things we do is we try to treat that diagnosis right away. We might give them some medicines or something to try to kind of cause the lining of the uterus to slough off and no longer have those hyperplastic cells. And so, yes, it is one thing that if it was not treated, could definitely increase the risk of endometrial cancer. Hey, Jackie, thank you so much for joining. I appreciate y'all being here. So, so that's the first of the three things that I want you guys to keep in mind about endometrial cancer or uterine cancer. That there are risk factors that include increased estrogen in the body. Things that can cause increased estrogen in the body include polycystic ovarian syndrome, obesity, diabetes, and sometimes in certain studies, hypertension. So again, those are just some things to be mindful of. Those are some things. The good news is that for some of those things, there are things that all of us can do, and many of us can do to decrease our risk. So that's one of the positive things about some of those risk factors. So what about some things that can reduce risk? One of the things that has been talked about in the literature is the impact of birth control pills. So when a woman is still having in her reproductive years, and reproductive years usually started about age 11. I know for all my friends who have daughters, they're like, is it 11? Yeah, it's age 11. The average age of when young women start their menses is age 11, up until about the average age of menopause is 51 in this country. And so when we look at those reproductive years, if a woman is having her regular cycle, and if she chooses to use birth control pills as her contraceptive method, she is actually, over the long run, going to reduce her risk of endometrial cancer. And the reason for that is related to what we talked about in terms of increased risk. When women take birth control pills, it helps to balance out the hormones so that you don't have the same type of hormonal imbalance that can increase someone's risk of endometrial or uterine cancer. Okay, so that's something that's very important to keep in mind. Also, things that can reduce risk, if you don't have a family history, that certainly keeps you in the quote-unquote normal risk category. Another thing that I didn't mention in terms of increased risk is being 55 or older. Most cases of endometrial cancer, when they're diagnosed in women who are postmenopausal. Now, there's certainly room in women who are in their 40s and early 50s if they haven't gone through menopause. There are some cases that have been diagnosed in younger women as well. But when I talk about this next thing in terms of symptoms, you'll understand about why it might be important to screen for certain things, to be able to detect things early on in case they are potentially present. Okay, so the first thing we talked about was risk factors. The second thing we talked about was things that can reduce risk, things like reducing your overall BMI, being on birth control pills during your reproductive years. And the third thing we're going to talk about is symptoms, okay? Now, for endometrial cancer, one of the reasons it's so important to be aware of symptoms with some of these GYN cancers is that for many of them, we don't have a really strong screening technology. The one GYN cancer for which we have a great screening is cervical cancer. And you guys probably are aware the Pap test is by far one of the greatest screening tests put out there because it can detect cervical cancer before we see any symptoms. Now, that's a really good screening test. A screening test is, it's really good when it can pick up on something early before you have any symptoms, and by picking up on it early, it can alter your treatment and potentially save your life in terms of uh, cutting short the amount of time that you had something in your body without being aware of it. So the most important thing of these symptoms that I want you to be aware of in terms of endometrial cancer or uterine cancer is any bleeding that happens post-menopause, okay? And by menopause, if you guys recall, we've talked about this in earlier talks, menopause is officially when you reach 12 months of not having a menstrual cycle. I know there are many women I know who come in or call and they're like, Doc, I'm at month 12. I think this is, Doc, I'm at month 10. I think this is it. And then maybe month 11, they'll have another cycle. So technically that woman has not yet gone through menopause. And her clock starts back to month 1 if she has gone 10 months and in that 11th month she has her cycle. Her 12-month calendar starts all over again. But if you have someone who's postmenopausal, they had a full 12 months without a cycle, and then something happens, let's say they had sex and the sex was painful, and then they had some bleeding afterwards, and she's already postmenopausal, that is a, hey Patricia, thank you so much for joining. Thank you. I appreciate you being here. Yes, bleeding postmenopause is one of those things that absolutely, if it happens to you, if a sister friend calls you and says, hey, girl, I was without my period for 2 years and then all of a sudden I had some bleeding again, I want you to encourage that sister friend to go see her provider. Because whenever there's bleeding postmenopause, it has to be assessed. We have to basically get a biopsy of that endometrial tissue. The biopsy procedure is usually very straightforward, usually done right in the office. It can be done with something we call a pipelle. It's a very thin device that can go through the cervical canal up into, so it basically, you can do it just like a pap almost. So it comes through the speculum, comes into the cervical canal, and goes up into the endometrium and basically scrapes some tissue. And then we send that tissue to the pathology lab, and then the pathology team tells us whether or not that tissue from the endometrium is just hyperplastic, like Janet asked about earlier, or if it's something more severe, something of more concern that requires a different type of management, a more aggressive management, like a endometrial carcinoma. And so that's absolutely the most important symptom that I want you guys to be aware of, is bleeding, any bleeding that happens post-menopause. Now, let's say you haven't gone through menopause, but your cycle just becomes very, very irregular. You're bleeding in between cycles, your cycles are heavier than normal. One of the normal things that we would do as part of that workup is, yes, we would work you up to see if there are fibroids and all of that, but we would also, especially if you're age 35 or older, we would offer you, usually your provider would offer you an endometrial sample, endometrial biopsy. Because again, although endometrial cancer is more common when you're postmenopausal, if you're premenopausal and your cycle suddenly becomes very irregular, it is it's very important to check out the lining of that endometrium just to see what's going on, just to make sure that maybe it is just hyperplasia and just some medicine, or sometimes the bleeding is so heavy that a D&C is required. But maybe it's something more benign that can be treated very easily, and if so, that's great. But if not, that biopsy of the endometrial lining is definitely going to give us vital information that will help with your overall care and treatment plan, and possibly even save a life. Because again, as I showed you in the beginning, and I don't know if I said this also, but thank goodness most endometrial cancers are diagnosed just when they're at this stage, just when they're at the stage of the lining, okay? So I think the estimate is about 70% of cancers, endometrial cancers, are diagnosed just when they're at the lining. And what does that mean? That means that if the cancer is just at the endometrial lining, there's a 90% chance of survival if the treatment is done in a reasonable amount of time. Treatment for most endometrial cancers, and again, your regular GYN would probably send you to a GYN oncologist, but the treatment for that type of cancer usually involves a total hysterectomy, along with removing the ovaries, the uterus, and the cervix. And it's done that way to make sure that all possible endometrial cancer is removed from your body. The other thing that they do when they're doing surgery for endometrial cancer is they check the lymph nodes to see whether or not any cancer cells have gone into the lymph nodes. They will usually, there in the operating room, cut open the uterus to see whether or not that cancer is still just on the lining or if it has moved into the uterine tissue. So that's just something to keep in mind in terms of endometrial cancer. So again, the three things I want you to be aware of as we talk about endometrial cancer or uterine cancer. Remember, those are the same thing. They just have to do with how far into the uterine wall the cancer has grown. And so I want you to keep in mind the risk factors, the things that we can sometimes have an impact on, like a BMI 26 and over. Again, I'm in that category too. I'm working hard to get that BMI down so I can potentially decrease that risk. Also, diabetes is one of the things that can increase risk. Unopposed estrogen, so when women have polycystic ovarian syndrome, that's one of the things that can cause estrogen to be increased in our bodies and can potentially increase risk for endometrial cancer. The second thing I want you to be aware of is things that you can do to decrease risk. We talked about potentially, working on decreasing our BMIs. Again, myself included. Sometimes people feel some type of way, so I always like to make sure people know that I'm talking about myself as well. And then, if your reproductive age, if you were going to be using something for birth control, and birth control pills is what you chose anyway, and birth control pills are tied to a decreased risk later on of endometrial or uterine cancer. Hi, Tyson. Thank you so much for joining. I appreciate you being here. Hi, Cheryl. Thank you so much for joining. I appreciate you being here. Cheryl has asked, will having an endometrial ablation lower your risk for cancer? Great question. So for those of you who may not be aware, an endometrial ablation is something that you can do. Let's say you have some abnormal bleeding and you have a biopsy done, and the biopsy shows that the cells on your endometrial cavity are normal. They're benign. There are no cancer cells. Sometimes your provider, your GYN, might offer you something called an ablation. And an ablation just means that in the OR, or at least under some sedation, maybe you won't be all the way asleep, but you'll have some sedation. We go in with a device that has like kind of a ball at the end, and that ball has some heat on it. And what we do is we apply that heat throughout the intrauterine cavity as a way to kind of burn that inner layer, that endometrial layer, so that the bleeding stops, or at least is significantly decreased. An ablation would possibly lower your risk if it's already, sometimes there are women who have an ablation and they hadn't done the part where you check for, where you do the biopsy to make sure the cells are normal. But if you've done the part where the biopsy has been done, it's documented that the bleeding is not tied to any abnormal cells, then that endometrial ablation, by decreasing the abnormal bleeding, should in some way lower your risk. However, remember, that ablation doesn't alter hormones. So if the root cause of the abnormal bleeding is due to hormones being unbalanced and some other things, it doesn't necessarily, the ablation won't necessarily reduce or remove that foundational cause. And so it's a matter of understanding or examining with your GYN what other factors might be going on, so that you could be sure that if you do this ablation, you're going to overall decrease your risk based on the factors that are going on. Hey, Dr. Bobby. Hi, thanks so much for being here. I appreciate all of you guys being here. So again, I just want to summarize. Today we talked briefly about endometrial cancer, which some people also call uterine cancer. And you guys, I know I've said it a few times, but just to summarize, uterine cancer and endometrial cancer are the same. It just depends on how far the cancer cells have grown into the endometrial cavity and to the uterine wall lining. Okay, so they're the same thing. The first thing we talked about were risk factors for endometrial cancer. Anything that increases estrogen in your body without opposing progesterone can potentially increase your risk for endometrial cancer. That includes obesity, includes diabetes, includes polycystic ovarian syndrome, includes some women who might take estrogen and not know that they have to take progesterone to make sure that there's a balance. I sometimes have patients who might start having hot flashes, and maybe they have an older woman friend or their mom or sister friend who's not far away who has some estrogen pills, and sometimes they might borrow a pill or two to try to help with their menopausal symptoms before they can get in to see their doctor. And probably taking one or two is not bad. That's not going to harm anything on the short term. But in the long run, if let's say someone comes in and they've been taking a family member's estrogen pills for several years, that can be harmful, especially if their uterus is still in place, because that estrogen always requires an opposing hormone so that the body is in balance. Okay? And so, again, things that can increase your risk, things that can decrease your risk, that was the second thing. And the third thing is those symptoms to look for. Any bleeding that happens after menopause, if you have like any unexplained or sudden bloating, if you suddenly have pelvic pain that wasn't there before, sometimes it could be pain during sex, sometimes it can be pain during a bowel movement. Any of those things are things to just, write down in your notebook or on your phone, and make an appointment to see your GYN. And by writing those things down, you won't forget to ask those questions. Or sometimes if it's really urgent, I say, just call the office. Or if your provider has an email or online service, use that as well so that you can be sure to get the information that you need in a timely manner. And sometimes even get an appointment and come on in. And, and talk with them, make sure you share your entire history. Your provider's probably going to do a physical exam. And like I said, if they do need to do a sample, they can usually do it right there in the office, an endometrial sample. Okay, we have another question. Hello, Dr. Madeline. Thank you for providing information and resources. Having endometriosis, my doctors are informing me that I need surgery. Is it possible for me to simply treat, or do I place myself at risk for cancer if I don't have the surgery? Oh, thank you so much for that question, Ms. Smith. So definitely talk with your doctors about all the options. For endometriosis, there are a range of treatment options for you. Sometimes there's a birth control pill that can be used that can shrink the endometriomas. It depends on how much pain you're having. It depends on how long you've been having your symptoms, if your symptoms are affecting your quality of life. If they are discussing surgery with you, then it might be that you've had a lengthy process. But again, make sure you ask them questions about all your options so that you feel that you have as much information as possible before you sign the consent form to do surgery. Surgery is absolutely one of the treatment options for endometriosis. And sometimes when patients have surgery, it's after they've tried a few other things. And so absolutely make sure that you're comfortable if that is the next step that your doctors are discussing with you. Make sure that you're comfortable. Go through your own history to recall to yourself what other treatment options you've tried already, which things maybe you haven't tried that you might be interested in trying. And if you're still not sure about surgery, certainly no harm in seeking a second opinion, just to make sure that you are that you're ready for surgery. Surgery is a big deal. Everyone has to definitely be ready and feel that they've received all the information that they need so that they're making the best possible decision for themselves and for their health. Okay. Debbie has a question on hot flashes, 10 plus years or worse. Question on hot flashes, 10 plus years. Hot flashes, they're an interesting symptom. Every woman is so different when it comes to hot flashes. A lot of times the number of years will vary. Some women will have hot flashes for just 2 to 5 years after going through menopause. For some women, hot flashes start before they officially hit that 12-month mark of no cycles for menopause. And then for other women, I've had some women who, they're well into their 70s and they've been menopausal for 10 plus years, and they may still have hot flashes, although they may not be as severe as when they first went through menopause. So it really varies. One of the things that's important to do is to talk with your provider to determine if there's like a treatment that might work for you. Sometimes that can be bioidentical hormones that they can have made at a certain type of pharmacy, and it can be just for you. It can be a lotion or a cream or something. Other times it might be taking hormone replacement therapy, which again requires important conversations with your providers, because they know best your based on whatever history you've shared, whether or not there's any heart disease risk, any disease related to breast cancer and other things. So yeah, unfortunately, hot flashes are one of those things that a lot of times women deal with for a very long time, even after they're postmenopausal. But the good news is there are a range of treatments, and I certainly encourage you to talk about all the different options with your provider, just to make sure you have all the information about all the things that are out there. I also have some patients who don't want medicine at all, and they want to do completely natural treatments, and so that also works for some people. So good luck, Debbie Brown. I'm sorry that you have 10 plus years of hot flashes. I agree, it's the worst. And then there are some women who go through menopause and will barely have a flash at all. You know, they're very lucky, I guess. Okay. And Tyson Smith says, thank you. Oh, you're so welcome, sweetie. You're so welcome. I hope that that answer gives you something that you need to continue the conversation with your GYN. So thanks again, everyone. I want to thank you for joining me today on this Sunday chat with Dr. Madeline. And to wrap up, I just again appreciate all of you being here. I am Dr. Madeline, your board-certified OBGYN, international speaker, and published author. Oh, wait, I'm sorry, one more question. Patricia asks, at what point should a woman be concerned if she's still menstruating? For instance, still having cycles into mid-50s. Girl, I feel you. I have women who ask that question all the time, still having monthly cycles. One of the things that you don't necessarily have to be concerned unless you have some other things going on. So if you're seeing your GYN, if you're having your regular checkups done, if they've measured your hormone levels and your hormone levels are still in the range where it says it's okay for you to have cycles, it's okay for you to have cycles. You might also be one of those persons who genetically, sometimes it's related to, you know, how long your mom had her cycle. And if she was into her 50s, then that might be your path as well. And like I said, it could be completely normal. If it becomes something where it's not happening at the same time every month, or it's getting really heavy, or something else is unusual about it, again, that's something to mention to your provider in case they need to do one of those endometrial biopsies that I was talking about. But yes, now I would say if you get to, like, I don't know, 55 or 56 and you're still menstruating, or let's say they start to become a little bit unusual but they're not all the way gone, again, just keep those conversations going with your GYN, because a lot of times we choose to do an endometrial biopsy when someone is in their mid-50s, just to make sure we're not missing anything. Because, you know, one of my favorite anatomy teachers from med school always taught us, you know, the body doesn't read the book. So sometimes the body is doing things, and just to make sure we're not missing anything, the way to know 100% for sure that everything is okay is to get a biopsy. And a biopsy going to pathology is always going to give you the answer, just to make sure everything is okay. All right? So Patricia, I'm sorry if you're still having cycles into the mid-50s, or if you know someone who's having it into the mid-50s. It's definitely not pleasant. But as long as you're otherwise healthy and your GYN visits are otherwise healthy, then I would say just keep on top of them, keep track of them, and you know you'll get to that last one eventually. I promise. Oh my goodness, Debbie, yeah, your menopausal symptoms started right after surgery. Yeah, that can happen abruptly for those women who go through menopause due to surgery. Let's say they have a hysterectomy in their early years and they don't reach that average age of 51 where they have their ovaries and uterus there in their body. They can absolutely start menopause as soon as they have a surgery that removes their uterus and ovaries. And so definitely in those situations, you know, talk with your GYN surgeon. Sometimes women need just a few months of some medicine to help them through that peak, that sudden stop of hormones. and absolutely, talk with your GYN in case that's something you might be interested in. A lot of times we'll start with the lowest possible dose just to make sure that that you can get what you need without having too much of the hormone in your system. Oh, thank you. You're welcome, Janet. Thank you so much for being here. Oh, thanks, Patricia. I understand. It's frustrating. Good genes, I guess. Thanks. Yes, great genes. I know, Mama Sylvain, you have great genes. Absolutely. Thank you, sis. As always, the best information. Oh, you're welcome, sis. I appreciate y'all being here. So thanks again, everyone, for being here today for this discussion about endometrial cancer. I'm Dr. Madeline, your international speaker, published author, and board-certified OBGYN. I am passionate about helping women, especially busy women, access the tailored GYN care and services that they need so that they can have more control and freedom over their lives. And I'm, again, appreciative of all of you joining me today. If you would like to get more information, please feel free to follow me on Instagram, Facebook, and Twitter. My tag is Dr. Madeline MD. That's DrMadeLineND. Thank you again for being here. I'll see y'all next Sunday, where the requested topic is the flu vaccine and the COVID vaccine, facts and myths, and what you should consider doing. Okay? Thank you so much. I appreciate y'all. Thank you, Michelle. I appreciate you being here. Thank you.